Right. So good morning, everyone. Thank you for coming to our coffee morning today, the 30th of November, 2020. Our speaker for today is an advanced nurse practitioner in oncology or cancer sciences. He will be talking about his pre-doctoral work. Essentially, it's work that he wants to do before he does his postgrad. I think it's PhD. He will be talking about understanding how people with cancer and nurses work together to manage risk during emergency telephone helpline consultations. So without further ado, I would like to give the floor to John Defty. John?
Thank you. Let me just see if I can share my screen and we'll get going. Okay, can everyone see that? Hooray.
Yep.
So my name's John. There's a slightly ridiculous picture of me. I'm a nurse by background, and in the clinical part of my role, I look after people who have cancer, who become unwell, either because of the cancer itself and complications, or because of side effects of the treatment for that cancer. So as introduced, I'm an advanced clinical practitioner. So much of my time is spent thinking about why people have come to me in our service to seek emergency care, and then deciding what to do about it. But I'm mainly here to talk to you about a research project that I have in store, and my role so far in research. So I'm funded by Health Education England and National Institute for Health Research pre-doctoral clinical academic fellowship. It's a bit of a mouthful, but emphasis there is on the pre-doctoral part. So unlike probably quite the majority of people who talk to you in these forums, who have either done research and are reporting the results, or are PhD students saying what they've done so far, I'm coming to you at the sort of the genesis of the project to talk to you about what it is that I've got in store, what are my thoughts so far, and then ultimately to start ramping up the involvement, engagement with public and patients to sound out whether this is on the right lines and how we're going to go about it. So hopefully you won't come away from this feeling shortchanged. But the reason for the pre-doctoral award, as I've sort of alluded to in the introduction before everyone was here, I made a commitment to the NIHR, to the public, myself, patients, to involve people meaningfully from as early as possible throughout this process. So this is one little way that I can make good on that promise by talking to you today. So thank you for the opportunity. So I'm going to talk to you about how far I've got so far with taking a problem that I've seen in practice and trying to turn that into a researchable question. I'd also like to say, as we go along, that if you are interested in anything I'm saying, you want to interrupt, please do. I really like interruptions, and I think that sometimes the best things come from interruptions in life. My email address, if you want to ask me any questions afterwards, or you'd like any more information about what I've said, is at the bottom of this slide. I'll try and repeat it at the end. I'm also aware that talking about cancer can be a difficult subject for many. And if you feel like you don't want to continue, or things are a bit too close to home, then please don't feel duty bound to continue. Just, you don't need to make your excuses, just be where you need to be. So on to business. So the title of the presentation is My Working Research Question. So how do people with cancer and nurses work to manage risk during acute oncology telephone consultations? But before we go into that in any more detail, I need to talk to you about where that idea has come from. So before we go any further, if you can, I mean, I've got a few faces down the panel, but put your hands up if you have ever heard of an acute oncology service and know what it does. No. So I can't see many responses, but so far no one's put their hand up. So it kind of, as I suspected, it's kind of hidden work in the urgent and emergency care landscape. So acute oncology is a part of cancer care that aims to manage and coordinate the care for when people become unwell because of cancer or its treatment. It also tries to prevent adverse events happening in the first place. And it's also part and parcel with the diagnosis of cancer as an emergency. particularly in a group of patients who have something called cancer of unknown primary. So where we know that there's cancer in the body, but we don't really know where it's come from. So it's a multidisciplinary specialty. It's varied, but it's also very new. So treatment for cancer is getting more complex. Even over the last 5 years, I've seen, a more mass rollout of immunotherapy treatments for various types of cancer. And only a few weeks ago, we saw the start of CAR T cell therapy for lots of blood cancers. And it's a cutting edge treatment for blood cancer and Southampton is one of the second stage rollout of that. So things are changing all the time, but treatment for cancer can be tough. It can be tough psychologically. It can place demands on your time, your finances, your family unit. And severe complications of cancer and its treatment in themselves can be life-threatening. So the result is that for many, they find themselves having to use urgent and emergency care along the course of their treatment for cancer. In 2008, a national confidential inquiry into the care of people who had died within 30 days of receiving chemotherapy raised some concerns about the quality of care. It found that due to kind of a disjointed emergency care system, the professionals giving the chemotherapy weren't always the ones who were looking after the side effects. With many patients admitted under general medicine or general surgery, and there's a consensus that in about 49% of the care that was reviewed by the report, there was room for improvement, and only 35% of people were, in the report's opinion, given good care. So there's clearly room for improvement at that time. It also showed that people often delayed reporting severe side effects or life-threatening side effects of treatment for up to 24 hours. And a year later, the National Chemotherapy Advisory Group recommended in a report that all hospital trusts that have an emergency department or like an open front door develop something called an acute oncology service as a way of streamlining pathways of care for emergency cancer care. Now, that can either be an assessment unit or an in-reach service, and they've developed heterogeneously across the UK, but that's the standard that trusts now have to meet. So one of the key features of these services is a 24-hour telephone helpline that patients and carers can ring if they feel unwell or have concerns. And looking into the near future, these helplines are likely to get busier. I imagine that many of you will have heard that 1 in 2 of us will now be diagnosed with cancer across our lifetime. And the reality of one of those projections looks like for the UK, over this decade, there'll be an extra 1 million people in the UK living with cancer. So we've got a new service, and it's designed to make emergency care safer. It's probably going to be used more and more over the coming years, but there's limited research guiding it. So in the case of these acute oncology helplines, the next question that we've got to ask ourselves is, why can't we use existing research to help us understand how to help people better? There's research about NHS 111 and its predecessor, NHS Direct. There's evidence about nurse-led telephone triage. What's the problem? Well, if I could ask you another question, who here has ever had to ring NHS 111 or 999 for a health problem for themselves or somebody else?
Yeah.
Okay, so I think a few of you. How many of you thought that the outcome of that would be that you develop a relationship with that service? So I'm not hearing an awful lot, and I can't see many hands, but I think this is a unique thing about these services. So one of the things here is that people with cancer may need to ring the acute oncology helpline multiple times over multiple courses of treatment appropriately. The mantra in clinic is, or on the discharge hospital paperwork, if you've got a problem, just ring. The complications of these treatments can be nuanced and complex and be quite difficult to understand. So it's more than just a one-off intervention service. It's more like a relationship that forms over time for many. It's not just a kind of, we'll book you an appointment. It's not just triage. It's not just a transfer to hospital. The helpline will call people back the same day or call people back over multiple days as part of supported self-management, as well as arranging emergency admissions. It will connect with other members of the cancer team, a GP, as well as part of a coordinating service. So perhaps this is the interesting bit, and I'll be interested to see what you think in the Q&A, but understanding how the call handler and the patient work together to understand the risk attached to the problem for which the patient has contacted the helpline may help us understand how we can support more people to manage their side effects of treatment at home and avoid hospital admission. Unlike many telephone delivered emergency care services, is for the most part also delivered by cancer nurses as opposed to generalists such as GPs or paraprofessionals such as NHS 111 call handlers. So people who are trained to do that role but are not professionally registered. It's also a service designed to meet the needs of a complex patient group. So using research from other areas will probably only get us so far. And I think this problem reflects a larger challenge with cancer research, that actually, for the most part, there is very, very, very little evidence for acute oncology services. Quite a lot of evidence exists around the right course of treatment for the right cancer and its supportive medicines to make the side effects better. But in terms of service delivery, there isn't an awful lot out there. So I've started involving patients in the run-up to my doctoral application, and actually this has been really interesting and has brought me an awful lot of insight. The most crucial thing for me is that people have been surprised that there isn't an awful lot of research into this subject there, and it seems quite close to people's hearts. So listening to people's experiences has also been quite interesting to hear. So people, it seems to be that people's motivations for ringing were often to seek reassurance, but were surprised when they are asked to attend hospital. So there's a potential conflict there between what people's expectations were versus the reality of the advice they were given. I think some hope to be told that, oh, don't worry about it, it's part of the course, it's nothing to worry about. And actually the nurses on the helpline were more concerned than perhaps the patient was expecting. So we also talked about how lots of people were learning how to be a patient with cancer and using the telephone. And everyone who I spoke to was concerned about the helpline being taken away, which shows something about the importance of this service to patients. So how might a research project in this area be designed? It's important at this point to think about what we mean by risk. I would define risk in this setting as threats to the health and well-being, including death of the caller. But it's possible that the way people with cancer and nurses handling the calls perceive risks for individual patients differently. From my own experience, some patients have thought that the risk of interrupting or provoking delays to their cycles of treatment may be a bigger risk than the side effects and getting them treated. Now that's my own experience, and I need to be mindful of that when I start the research. But situations like this may give rise to tensions that need to be understood in order to agree a way forward when it comes to the conversations that happen on the telephone. People might be scared of having to return to hospital, and equally, people may want to return to hospital to get things checked out when actually the situation is very able to be safely managed at home. All of this matters because an ongoing relationship with the service is needed to make sure complications are managed appropriately and in a timely manner. Experience matters because if it's a bad one, people might delay calling with the potential of avoidable harm resulting. So there's two sets of actors at work here, patients and nurses. So to understand how they work to manage risk, I propose, as part of a project, to collect data from both groups and in a number of ways. We often see papers on help seeking that have studied perceptions or experiences from one side, i.e. patients or professionals, but help seeking is a social process. In order to understand the dynamic of the interaction, we're going to need to study both caller and call taker. Because we're interested in experience and perceptions mostly, it seems to me that if not wholly, a qualitative approach, at least in part, seems appropriate as a way forward at this point in the research project. And as there may be a difference between what people think happens and what actually happens in practice, observation of the nurses, as well as interviewing them after the events is probably a way of getting more fruitful and rich data. Clearly, I can't observe people when they make calls, as in patients, because that would involve me hanging around in their house and waiting for them to become unwell. But at what point and timing after a call I interview them, and how to access them is something that I'm going to need to work with patients and public as part of my involvement and engagement measures to find out what's acceptable in these situations. And one way of getting more insight into what goes on in these consultations would ideally be to actually listen and transcribe, code and analyze the calls themselves. But again, the questions of how and when rise as challenges for implementing a research project like this. And do I try and link up with patients and interviews and the nurses as mini cases that are interconnected? Recruitment would be challenging in that setting, but equally, rich data could result. All these are questions that I'm going to need to involve patients and members of the public to ascertain what is acceptable in which circumstance, if at all. So, in terms of moving forwards, I probably posed more questions than answered and presented work on developing a research question far more than actual research. But I hope you found my presentation interesting and perhaps you've learned something new. I'm looking forward to any questions you may have and any challenges you may think I'll face along the way. But above all, thank you for your time. I appreciate the opportunity to present this talk to you, even if it has been sort of affected by the fact that I can't see everyone on the screen all at once and haven't been able to gauge everyone's reactions so far. If anyone is interested in the work that I propose doing, I'd be very welcome to hear from you, and feedback from this is very welcome. So if anyone's got any questions, I would love to answer any.
Thank you, John. Do you mind stopping your screen sharing so I see everyone, so we can cue the questions?
I certainly can.
I will stop recording.